Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. My email is sreeklpm@gmail.com. Today we are going to talk about a very interesting topic, cognitive neurology part 2, parietal lobe. Cognitive neurology part 2, parietal lobe. Parietal lobe. This part of the cerebrum lying behind the central sulcus and above the sylvian fissure is the least well demarcated. The parietal lobe is supplied by the middle cerebral artery, the inferior and superior divisions supplying the inferior and superior lobules. So you can see this is the parietal lobe. It is behind the central sulcus and above the sylvian fissure. It is least well demarcated. Parietal lobe. The primary sensory somesthetic cortex S1 areas 3, 1, 2 occupies all but the lowest part of the postcentral gyrus, continuing on to the medial surface into the adjoining part of the paracentral lobule. S1 receives enormous projections from the ventro-posterolateral and the ventro-posterior medial nuclei of the thalamus. These relay impulses from the spinothalamic tracts, which carry pain and temperature, the medial lemniscus or posterior column, which carries joint position and vibration sense, the trigemnothalamic tracts, which carry sensations from the face, which sends fibers through the posterior limb of the internal capsule to the postcentral gyrus. The body regions are represented in specific parts of the postcentral gyrus. The pattern roughly parallels the motor homunculus localization of the precentral gyrus but is not well defined. So we have a point-to-point representation of all the body parts, the sensation of all the body parts in the parietal lobe. The sensation, the representation of the sensations of the face and the hands are the highest in the parietal lobe. Therefore, the 2-point discrimination, that is, if the 2 points are applied, it is appreciated separately. That is known as 2-point discrimination. It is well appreciated in the lips, fingertips, because they have got the highest representation. So the 2-point discrimination, very sensitive areas are the lips and fingertips because they got the highest representation, whereas the back or thorax, they don't have a good 2-point discrimination, the appreciation of 2-point discrimination. So the sensations, the sensory homunculus roughly parallels the motor homunculus of the frontal lobe. The sensory homunculus, the sensations being the highest, the representation of sensations being highest of the face and the hands. So body regions are represented in specific parts of the postcentral gyrus. The pattern roughly parallels the motor homunculus localization of the precentral gyrus but is not as well defined. Till the thalamus, all the primary sensations are appreciated. That is the touch, pain, position, joint and vibration sense. But from the thalamus onto the parietal cortex, there are specific sensations which are appreciated by the parietal cortex. Since these are the sensations appreciated by the parietal cortex, we call that as cortical sensations. So parietal lobe lesions produce abnormalities of higher level sensory functions which require association cortex. So when the primary sensations, that is touch, pain, position, joint, vibration sense, are intact but the cortical sensations are affected, it implies that the parietal cortex is involved. So what are the cortical sensations which are perceived by the parietal lobe? Stereognosis. So stereognosis, we ask the person to close the eyes, give something like pen or keys and ask him to perceive it with his hands manipulated but with eyes closed, and he should be able to tell what is the object given in his hands. If he is able to tell correctly without looking at the object by perceiving and manipulating the given object in the hands, it indicates that the sensation of stereognosis is intact. That is stereognosis. Second is the graphesthesia. Again, we ask him to close the eyes. We put a number on his hands like 6 or 3. He closes the eyes, but when the number is put onto his hand, he should be able to appreciate it and say whether it is 3 or 6 or whatever number is written on his hand. If he is able to appreciate that, it implies that his graphesthesia is intact. The 2-point discrimination, as I said, when 2 points are separated very little and then kept on either the face or the lips or the fingertips, and if they are appreciated as 2 distinct and different points, that indicates that 2-point discrimination is intact. And the 2-point discrimination is highest in the lips and the fingertips, as I just discussed, because the representation in the sensory homunculus of the parietal lobe is highest for the hands and the face, and therefore the 2-point discrimination is well appreciated in the fingertips and lips, unlike the back. Tactile localization. The precise localization of a given tactile impulse is known as the tactile localization. So stereognosis, graphesthesia, 2-point discrimination, tactile localization, these are all the sensations perceived at the level of the parietal cortex, hence we call these as the cortical sensations. But to test the cortical sensations, the primary sensations, namely touch, pain, position, joint, vibration sense, should be intact. If they are intact and if the parietal cortical sensations are absent, it implies that the parietal lobe is affected. One of the very important functions of the parietal lobe, especially the non-dominant cortex, is the spatial orientation. The spatial orientation. The right parietal lobe, that is the non-dominant cortex, produces left hemi neglect, whereas the left parietal lobe, the dominant cortex, does not produce a right hemi neglect usually. Why only the right parietal lobe or non-dominant cortex produces hemi neglect on the opposite side, and why a dominant cortex does not produce hemi neglect onto the opposite side? The reason being, the explanation being, the right cortex, the right parietal cortex, controls both the right and the left extrapersonal space. The right parietal cortex controls both the right and the left extrapersonal space, as shown in the diagram, whereas the left parietal cortex controls only the right extrapersonal space, whereas the left parietal cortex controls only the right extrapersonal space. So if left parietal cortex, that is the dominant cortex, if it is affected, the right extrapersonal space is also affected, but this is compensated by the intact right parietal lobe, which controls both the right and the left extrapersonal space, and therefore the dominant left parietal cortex does not produce right hemi neglect. On the contrary, at the other end of the spectrum, if the right parietal lobe is affected, both the right and the left extrapersonal space are affected, but the right extrapersonal space is compensated by the intact left parietal lobe, but there is no compensation on the left extrapersonal space, and therefore right parietal lobe or non-dominant cortex produces left hemi neglect. Very important. You can see in the diagram that the right parietal lobe controls both the right and the left extrapersonal space, whereas the left controls only the right extrapersonal space. So if the right is affected, both are affected, but this is compensated by the intact left parietal lobe, so they'll have left hemi neglect. Whereas if left is affected, only the right is affected extrapersonal space, but that could be compensated by the intact right parietal lobe. So it is the right parietal lobe lesions, the non-dominant lesions, which produces left hemi neglect. And how do we examine it? We can examine it at the bedside by drawing a clock with 12 numbers. You can see on the second diagram that there's a clock with 12 numbers. Generally, when we are asked to draw a clock with 12 numbers, we place it or we space it equally. The 12 numbers, the first 6 on the right side and the left, and the next 6 numbers on the left side. But persons with right parietal lobe lesions or non-dominant lesions completely neglect the left side, so that they put all the 12 numbers on the right side. They completely neglect the left side. So you can see in the diagram that the right parietal non-dominant lesion, which produces left hemi neglect, all the 12 numbers are on the right side of the clock. So when they are asked to wear trousers or shirt, or in males when they are asked to shave, they shave only on the right side. They wear trousers or shirt on the right side, they completely neglect the left side. If the illness is so severe, they even deny the existence of the left side of the body. That is called as anosognosia. Denial of disability culminating in denial of owning their contralateral limbs. If you pinch their hands or legs, they'll ask whose hands you are pinching at. So they completely neglect the left side of the body. They deny, in fact, the existence of the left side of the body, which is known as anosognosia. Yeah, as I said, the inferior parietal lobe, the angular gyrus, is important in relation to language, calculation and spatial orientation. Angular gyrus is important in relation to language, calculation and spatial orientation, and therefore when there is a left dominant parietal lobe angular gyrus involvement, they will have the tetrad of finger agnosia. They are not able to tell the name of the finger. If we put the fingers crossed and ask them which is the right index finger or the left ring finger, they will not be able to tell it. So that is known as finger agnosia. They will have right to left confusion. Ask them to take the right hand to the left ear or left hand to some other part on the right side, they totally get confused. This is known as right-left confusion. They have agraphia, difficulty in writing. They'll also have alexia, difficulty in reading. They'll have acalculia, they'll not be able to calculate. So this is the tetrad: finger agnosia, right-left confusion, agraphia and acalculia. When all the components of the syndrome are present, the lesion is likely to lie in the dominant inferior parietal lobule, particularly in the region of the angular gyrus. So one of the important concepts to be known is that the Gerstmann syndrome or the angular gyrus of the dominant parietal lobule produces alexia with agraphia. Alexia with agraphia, that is difficulty in reading as well as difficulty in writing. Whereas if it is a left posterior cerebral artery involvement which affects the left occipital lobe and the splenium of the corpus callosum, they will have alexia without agraphia. They will have difficulty in reading, but they don't have difficulty in writing, because when the left posterior cerebral artery is affected, the left occipital cortex is affected, so they cannot see on the right side. They will have right homonymous hemianopia. So whatever they need to see, it comes from the left side of their body, it goes to the right occipital cortex, but then it cannot access the language areas because they are on the left side, because it has to traverse the corpus callosum and access the language areas on the left side. But since left posterior cerebral artery affects not only left occipital cortex but also the splenium of the corpus callosum, the information, the visual information cannot be traversed from the right occipital cortex to the language areas which are on the left side. So these persons have right homonymous hemianopia because of the left PCA stroke and left occipital lobe involved, and the visual information from the right occipital cortex cannot access the language areas which are on the left side because the splenium of the corpus callosum is also affected because of the left PCA infarct. So they cannot convert the visual information into a language form. So they cannot read. That is alexia. They don't have any problem with writing because writing goes anterior to these parts. So they don't have any problem with writing. In fact, a blind person also can write. They don't need occipital lobe. So these persons, left PCA infarct, they produce characteristically alexia without agraphia. These persons write but they cannot read what they have just written. So alexia without agraphia is seen in left posterior cerebral artery lesion involving left occipital cortex and the splenium of the corpus callosum, but alexia with agraphia, that is difficulty in reading and difficulty in writing, are seen and they are part of the Gerstmann syndrome. The other components being finger agnosia, right-left confusion, acalculia and agraphia with alexia. Homonymous hemianopia. The vision goes through the optic nerve. The nasal fibers representing the temporal fields cross, whereas the temporal fibers do not cross, they go straight. And then finally they go to the lateral geniculate body. The optic radiations goes to the occipital cortex. So post-chiasmal will produce hemianopia, one-sided hemianopia. The representation is the opposite side. The nasal fibers represent temporal field, temporal fibers represent nasal field, superior fibers represent inferior field, inferior fibers represent superior field. Since the optic radiations travel superiorly in the parietal lobe, if there's a lesion there, they'll have homonymous hemianopia, but the inferior part gets affected, which is known as inferior quadrantic hemianopia. So the optic radiations course through the deep parietal lobe to reach the visual cortex. A deeply placed parietal lesion may cause either an inferior quadrantic or hemianopic visual field defect. So these are all the important concepts of the parietal lobe. Summarizing the important points of the dominant parietal lobe and the non-dominant parietal lobe. First, we shall see the parietal lobe dominant. Summary: the action, the functions, and the effects of damage in terms of cognitive, behavioral, associated physical signs, and positive phenomenon. The functions of the dominant parietal lobe are language and calculation, and the effects of damage in terms of cognitive, behavioral aspects are dysphasia, agraphia. As I said, they can cause agraphia, they can cause dyslexia or alexia because of the involvement of the angular gyrus, acalculia, they'll have apraxias, especially idiomotor apraxia, they can have agnosia, asimultaneagnosia, that is, they cannot integrate the center of the vision with the peripheral of the vision, especially when the occipito-parietal connections are affected. The associated physical signs because of the effects of damage are contralateral hemisensory loss, especially they'll have the cortical sensations being lost, that is agraphia, stereognosis, 2-point discrimination, and tactile localization, that is astereognosis, agraphesthesia. They'll have contralateral homonymous inferior quadrantanopia, and they have asymmetry of the optokinetic nystagmus because the saccadic pathway comes from the frontal eye fields area number 8 to the PPRF, whereas the pursuit pathway comes from the same parietal lobe to the PPRF. So if the parietal lobe gets affected, the pursuit movement towards its side gets affected. So when you test it with a rotating drum, when the parietal lobe gets affected, the fine pursuit movements gets affected, so they'll have asymmetry of the optokinetic nystagmus. And the positive phenomenon is that they'll have focal sensory seizures. The parietal lobe non-dominant, the summary is that the functions, the effects of damage in terms of cognitive, behavioral, associated physical signs, and positive phenomenon are: the non-dominant lobe is basically concerned with the spatial orientation. So when the right parietal lobe or non-dominant cortex gets affected, they'll have left hemi neglect. They'll have spatial problems. They can have constructional apraxia or dressing apraxia. They'll not be able to dress well. They'll not be able to construct well. So they'll have constructional apraxia, and they'll have hemi neglect. Basically, they have to do with the spatial orientation. The effects of damage in terms of cognitive behavioral effects are: they'll have hemi neglect, neglect of contralateral side, spatial disorientation, constructional apraxia, and dressing apraxia. The associated physical signs, the effects of damage are contralateral hemisensory loss, astereognosis, agraphesthesia, contralateral homonymous lower quadrantanopia, again asymmetry of optokinetic nystagmus. The positive phenomenon being focal sensory seizures. Yeah, these are all the important concepts of the parietal lobe. I hope you have enjoyed listening to my lecture as much as I have enjoyed delivering it. Almost all the important concepts of neurology I have put it in a book called Focus Neurology. I am the medical author of the book Focus Neurology, which is available online from all leading booksellers, including Amazon. If you have any suggestions or comments, you can post on to my YouTube channel, Dr.Sreenivas Medical Concepts, or you can email to my email cklpm@gmail.com. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.